All right, since we do have so many new folks joining us today, I think we'll do a round of like rapid fire introductions before we hand it over to some of the speakers joining us today. Um, so I will kind of facilitate that to move us along quickly. Um, Thank you all again for joining. I'm Anna Brulette. I am BBF's Building Bright Futures Policy and Program Director and help facilitate these child outcomes accountability team meetings. So I'm gonna hand it to Beth and then Becca and then Linda. I'll kind of tee up a couple of people at a time. So just name an organization would be great.
Morning, Beth Trzanski, also from Building Bright Futures. I'm a little under the weather today, so sounding a little froggy, but it's good to see you.
Morning all, I'm Becky Webb. I am a UPK coordinator.
Good morning, Linda Michnowitz, Regional Manager, BBF Regional Manager for Northeast Kingdom and Lamoille counties.
Perfect. Thank you all. All right, I'm next gonna have Katie Selena, then Jen Fortman, and then Kaya.
Morning, everyone. I'm Katie. I'm the Policy and Research Analyst for Let's Grow Kids.
Hi, I'm Jen Fortman. I am parent rep for Building Bright Futures.
Good morning. I am Kaya Ganguly, Director of Trauma Prevention and Resilience Development for the state of Vermont.
All right, thank you all. Lila, you're next on my screen, then Mariah, and then Megan Masterson.
Good morning, everyone. I'm Lila Bennett. I'm the Executive Director of Journey to Recovery Community Center in Newport, Vermont.
Hi there, I think I was double muted. Hi, I'm Mariah Ogden. I am with the Division of Substance Use Programs here from the Clinical Services Unit.
Hi, everyone. I'm Megan Masterson. I'm the Assistant Director at KidSafe Collaborative, which is based in Burlington, Vermont.
Awesome. Thank you all. All right, next we have the other Megan joining us today, Megan Mitchell, and then my colleague Darla, and then Maria White.
Hi, Megan Mitchell, Director of Clinical Services, Vermont Department of Health, Division of Substance Use Programs.
Morning, everyone. Darla Senecal, a Regional Manager for BBF, Addison, Rutland, and Bennington County.
Hi, everyone. Maria White from Children Integrated Services in the Child Development Division.
Okay, next we have Jill, Margaret, and Cooper.
Hi, I'm Jill Pearl. I'm with Children's Integrated Services, the Child Development Division, and I oversee specialized childcare. Good morning.
Hi, I'm Margaret Urban with the Vermont Department of Health, Strong Families Vermont Nurse Home Visiting Program Administrator in the MCH Division. Good morning.
Hi all, I'm Cooper. I'm the Program Manager at Help Me Grow Vermont.
Thank you all. Okay, almost through. Next I have Wendy and then Anne, who's introduced herself in the chat. Sorry, folks aren't feeling well. Wendy and then Keely and then Lauren, if you're able. I know you're also not feeling well. If you're able to unmute, you'll be next.
Wendy Hubbard, if you're referring to this, Wendy, I'm the Maternal Child Health Coordinator and School Liaison for the Health Department in Morrisville and on the Lamoille Council.
Hi, everybody. I'm also feeling under the weather. It's just that time of year, I guess. My name is Keely Agan. I use she, her pronouns, and I'm the Early Childhood Nutrition Manager at Hunger Free Vermont. Nice to see y'all.
Good morning, everyone. Lauren Smith, Help Me Grow Coordinator with MCH. And apologies again for being off camera. I will be listening and participating as much as possible, but managing a few patients at home today. But good to be with all you.
Thank you, Lauren. It is indeed that time of year. Lots of sick kiddos and sick folks. All right, almost through. I think people have moved around, but I think Renee, if you could go next, and then Anna, and then Danielle.
Sure. Good morning, everyone. Sorry, Anna, I came on late, so I'm probably the reason all your screen shuffled. Renee Kelly, Director of the Vermont Head Start Collaboration Office, which sits within the Child Development Division. And yeah, sorry to hear all of you who are managing illness right now, and knocking on wood on my side. Good to be with you all today.
Hi, I'm Anne. I'm the Child Development Specialist over at Help Me Grow Vermont. And like Renee said, I'm also excited to be here today with you all.
Good morning, everybody. I am Danielle Duquette. I'm with the Department for Vermont Health Access, and I'm sadly staying off camera because it appears I have limited bandwidth today. I am with the Payment Reform Unit with Medicaid.
Thanks, Danielle. Glad you could join us today. Okay, Brina, I think you are last unless this phone number belongs to someone who's not also on video with us today.
Hi, this is Katie Leffel. I'm a nurse coordinator with the Department of Health. I'm on my cell phone right now, so it might be me that you're seeing. I'm going to be home in about 20 minutes and be able to be on camera, but right now I'm just on phone.
No worries. Thank you for joining and introducing yourself. Brina, do you have capacity to unmute for a second and introduce yourself? Okay, maybe Brina is also in transit. All right, so we will kick things off. Thank you so much again for joining. I'm glad to see so many faces again, both new and old, for today's conversation. And we really are bringing folks together this month for the COAT meeting to focus on and better understand as a group the impact of substance use disorder on children and young children and their families in Vermont. And really hear from kind of states and more regional partners doing this work, and think about where there might be gaps or where we might want to elevate those resources in a different way in the early childhood world. And I want to do a special call out to our regional managers that joined us today. We're doing our best to do a better job kind of making this a table where we are really elevating issues and priorities that we're hearing from our regional councils. And this feels like a really great opportunity to kind of bring together both regional partners and folks working statewide on big challenges such as substance use disorder that have such a impact on kind of social determinants of health for young kids. So we are going to kick things off today with our partners who've joined us from DSU. And I'm going to give them the floor to talk, kind of orient us a little bit to the statewide resources available. So I believe Megan and Mariah, I'll hand the floor over to you all.
Great, and I will share my screen and hopefully be able to show some slides. I do want to just start by saying DSU oversees a portion of the services that are available for folks with substance use disorders. We do not oversee the entirety of the system. So Blueprint for Health and their spokes and community health teams obviously are incredible partners. And then also in the just private practitioner world, Department of Vermont Health Access, the Medicaid programs, there are many private practitioners who provide services to individuals and families with substance use disorders. So DSU has a subset. Let me see if I can figure out how to share this. Bear with me, I have about 30 windows open, which is why this has taken a while. There we go. All right. Let me see if I can make it. Slideshow beginning. There we go. Hopefully you all can see that now. All right, I got a thumbs up. Good. I can't see for many of you. So this is just a brief overview. So the Department of Health Division of Substance Use Programs actually has the entire continuum of care, from prevention and education all the way through intervention, treatment, recovery, and harm reduction. So we do cover and oversee services across the continuum of care. I wanted to start a little bit with some of our prevention work because some of these really are focused towards families, and many of our marketing pieces and educational pieces, such as Parent Up, RX Aware, One More Conversation, Let's Talk Cannabis, and some marketing around VT HelpLink are really great resources for parents, families, the Do Your Part as well. So I did want to do a shout out to our prevention and education pieces. Moving on to intervention and harm reduction. We do a number of programs and services in the intervention realm, school-based health services, which are pertinent to families and youth, our referrals and access to care through VT HelpLink. We also do a number of other educational pieces. And then harm reduction and overdose prevention, again, pertinent to families who may be struggling with substance use disorders. VDH partners with a number of the departments and divisions to make sure that Narcan naloxone is available in communities through syringe service programs, our recovery center partners, many of our treatment partners. We also have a great partnership with our recovery centers to make sure that if anyone experiences an overdose or is in the emergency department or hospital for a substance use related reason, recovery coaches are able to go and meet with that individual if they are willing and interested, and the recovery coaches can be great supports to help people navigate into treatment services or recovery services if they are interested. We also provide some support around recovery housing and transitional housing. Historically, that has been for single individuals, but we do have some of our vendors who are moving into recovery housing for people with children into that realm. So that's fairly new for us. So our intervention, our harm reduction, and community response initiatives are available statewide. As we all know, statewide coverage does not mean that every particular area of the state has the same number of services, intensity of services, number of service providers. We do know that in our more rural areas, up in the Northeast Kingdom, also down in our southeast kind of corridor, resources are not as heavily concentrated as you can find, obviously, in Chittenden County and in some of the other counties, but we do have statewide coverage. I wanted to talk a little bit because I think people get very interested in treatment, and people's understanding of what substance use disorder treatment varies. The state of Vermont, both the Medicaid program and the Health Department Division of Substance Use Programs, looks to the ASAM criteria, so the American Society of Addiction Medicine criteria, for determining patient placement and also treatment needs for people. So the ASAM criteria looks at the whole person. So it looks at what they call the 6 dimensions of the person, looks at their needs in all of those dimensions, and then is able to support clinicians in matching people to the intensity of treatment that that person needs, and then also where that person might need to receive that care. So the continuum of care. So ASAM also speaks to prevention and early intervention all the way through the highest level of treatment care. So ASAM looks at early intervention, so those educations, those high-risk folks, and then moves to outpatient services, so services where people are living in the community and then receiving treatment while they live in the community. Typically, that's going to be your individual counseling, your group counseling, your family counseling, your case management services. And thinking about Vermont's hub and spoke system, the hub and spokes are actually level 1 outpatient services. So people are living in their communities and receiving their services in the outpatient world. So the second and next step on intensity of services is intensive outpatient programming. So typically, when you think about the outpatient level, people are going maybe to an individual counselor once a week, maybe to a group once a week. Intensive outpatient programming is typically 3 hours of services at least 3 days a week. So someone might be going to group and an individual and seeing their case manager on one day. The next day, they might be having group and a family therapy session. The next day, they may be, again, having, a group and an individual session. So it's more intensive, but people are still living in their communities while receiving those services. So the next level is what people tend to be most familiar with, and that's residential treatment. So that is when someone actually lives in the treatment facility for a period of time while they're receiving treatment. So residential treatment actually has a number of different levels within it, from low intensity services. So you are living in that particular treatment facility, but you're spending more time connecting with your community. So there's less of the clinical services, more of how are you integrating back into your community, solidifying your recovery capital, making sure that you're able to then move back into the outpatient world successfully. And then there's kind of a mid-range, clinically managed high intensity residential, which is where you're getting clinical services on a daily basis. Most of the day is in clinical programming, but you don't need that kind of intensive nursing and medical care. And then the highest level of residential is the medically monitored intensive inpatient. That is when you're getting nursing care for part of the day, every day. You're probably seeing either a physician or a psychiatrist during that time. So that is the highest intensity. Think about that as one step down from a hospital. So you need that level of medical care. And then obviously there is inpatient care for substance use disorders as well. So the highest is when you're going to be in an inpatient or a hospital unit. And typically we think of that. The typical example is someone who is in alcohol withdrawal, who has a risk of withdrawal seizures. So they may need to be in a hospital with an IV, receiving medications to ensure that they don't have a seizure due to their withdrawal. So pretty wide continuum of care. So when thinking about accessing treatment services in Vermont, there is a flow to that. So typically a person is going to be screened by a clinician or other professional, or the individual decides, I need some help, I'm going to try and seek out treatment. So at that point, the clinician or the professional who screened the person or the individual themselves support the individual in reaching out to a treatment provider. Now that could be a preferred provider through the health department DSU system. That could be an individual therapist. That could be your primary care doc. So there's a variety of different ways someone may seek treatment for their substance use disorder. So once the person reaches out to the provider is going to do an assessment of the person's needs. So they're going to look at the whole person. They're going to use the ASAM criteria. They're going to look at all the dimensions of the person, and then they're going to make recommendations about what intensity of services they think that person needs based on their ASAM assessment and the appropriate level of care. So how much service do you need and where does that service need to happen? Provider makes that recommendation. It could be outpatient, And in fact, that's where most people land as far as what their service needs are. It could be intensive outpatient, it could be residential, it could also be a hospital, depending on that person's needs. And then really it's up to the person. So a person has every right to say, you've recommended me for residential, really what's going on in my life right now? I'm going to instead look for intensive outpatient services. So the referral happens and then the person decides, with what's going on in their life, what makes the most sense for them. So this is a statewide view of the specialty substance use disorder treatment. So the treatment that's overseen by the Department of Health DSU statewide. So we have a number of what Vermont calls hubs, but are called everywhere else as opioid treatment programs. Those are programs that primarily serve people with opioid use disorder. And provide a variety of FDA-approved medications as a part of people's treatment for their opioid use disorders. That could be methadone, that could be buprenorphine, and then there are lots of other variations of those medications that can be available at the hubs. Hubs tend to be pretty, for folks who have pretty intensive treatment needs, and or people who are on methadone. So methadone is not allowed to be prescribed outside of hubs for substance use disorders. Hubs provide daily medications for folks, can provide pretty intensive wraparound treatment services. They can address folks who are using more than one substance. So pretty high intensity service, but still outpatient. We have a number of high intensity residential programs statewide. So thinking about that ASAM continuum, it's the one step down from the hospital. So these are programs that provide 24/7 nursing care. Folks are able to access psychiatric and medical care in addition to their SUD treatment. So we have Valley Vista in Bradford, which is primarily serving men at this point. We have Valley Vista in Vergennes, which serves women. And then we have Recovery House in Wallingford that is co-ed. We also have a lower intensity residential program in Vermont that's located in Rutland. That's the Grace House program. And they provide lower intensity clinical services, more integration into the community, do not have the medical and the nursing services that are available at Recovery House and the Valley Vista programs. And then we have preferred provider outpatient programs scattered throughout the state as well. We do have statewide coverage, but again, as we all know, there are areas of the state which are more rural that have fewer programs than, say, Chittenden County does. We do have two hubs / OTPs that serve Vermonters that are located out of state. So in West Lebanon, New Hampshire, we have Habit Opco serving folks down in the southeastern part of Vermont. And then for folks in Bennington County, we are in the process of working with Green Mountain Care Board and hope to have a hub online in Bennington. But until that happens, there is an OTP just over the border in Massachusetts that is serving Vermonters right now. So this is just a snapshot of the preferred provider network. People sometimes get a little bit confused between the preferred provider network and the mental health designated agencies. So there are a subset of the designated agencies who also have certified preferred provider programs, but not all designated agencies are also preferred providers. And the preferred provider network actually has a pretty wide variety of types of providers. So we have everything from national companies all the way through privately owned private practices and kind of everything in between. We have a hospital, we have more than one hospital. We have several hospitals. We have an FQHC. We have small private nonprofits. We have small private practices and kind of everything in between. And we also have a number of programs that specialize in youth and adolescents and families. They are located in kind of the Chittenden County, Central Vermont area, but they do provide services for folks outside of those areas. Telehealth has actually been pretty helpful in being able to expand that reach. I touched briefly on the hub and spoke system. So VDH-DSU oversees the hubs, the OTPs. We actually, as our role as the SSA, which is a federal designation, we have some federal authority over the OTPs and the hubs. The spokes are overseen by the Blueprint for Health out of the Agency of Human Services Central Office. The Blueprint and DSU have always worked very closely together, and we do partner very well in kind of that split oversight. But the prescribers in the spokes, DSU does have some regulatory oversight of the prescribers, but not of the actual programming. So it can get a little confusing about kind of who owns which side of the hub and spoke equation. And just as a review, so the hubs are able to prescribe methadone, buprenorphine, all of the FDA approved medications for opioid use disorder. Spokes are able to do buprenorphine, naltrexone, which is also known as Vivitrol. They're not able to do methadone, and that's a federal regulation. So hubs in Vermont are OTPs, known as OTPs federally. Vermont requires additional services above and beyond what the OTPs are required to provide. So Vermont requires our hubs to provide what's called health home services, which is kind of that additional support to folks. Spokes are enhanced office-based opioid treatment programs. So like hubs in Vermont, we require our spokes to then provide the health home services as part of the community health teams. And the spokes receive staffing to provide those health home services. So Medicaid actually pays for one full-time equivalent nurse and one full-time equivalent LADC social worker, licensed mental health counselor per 100 Medicaid members on each prescriber's patient panel. Shout out to recovery centers, because there are lots of people who quite frankly achieve recovery without ever touching the treatment system. And the recovery centers are available statewide and certainly are serving people in the treatment system, but also a much wider group of people even beyond those in the treatment system. And I'm sure Lila will talk more about that. Mariah, you want to do HelpLink?
Sure. So some of you may have heard of, encountered, or accessed Vermont HelpLink. And if not, we can give you some information here today. So Vermont HelpLink is what we are promoting as really a front door to substance use services across the continuum. We launched it just about 3 years ago, early on in the pandemic in 2020, to ensure that folks still had a mechanism to access services, and they, when things were closing, they didn't feel as though substance use services are inaccessible. So this is our logo, Vermont HelpLink Alcohol and Drug Support Center. We can move to the next slide. And mine are not as, these are a lot more text heavy, not as beautiful, but the information here. So as a reference, we promote HelpLink as a single point of contact for people seeking information or support, resources, referrals, whatever, for substance use. People might use HelpLink to find resources for themselves, and we also see a pretty large percentage of folks, anywhere between a quarter and a third, who are calling on behalf of somebody else, so a third party call, and they might be calling for a family member, a friend, a partner, or clients. And you know, particularly for professionals who might not work in the substance use field but are close to it, such as some of you all, not needing to be the expert in those resources can be helpful. So it's available to anybody. People can access online. I have a link in here. It is vphelplink.org, or by phone, 802-565-LINK, or is that the toll-free option as well. The calls are taken, there's a certification, I think it's the Association Information for something. There's a link to what that means, but it's a similar certification to what the 211 call takers have. Screening and information specialists, and they're supervised by master's level clinicians. So a lot of the call takers, Vermont HelpLink call takers, are people who have lived experience. They're in long-term recovery themselves. Some of them work part-time as recovery coaches. They have personal and likely professional experience in substance use. So that is a staffing model, and I guess we can go to the next slide.
Formatting failed, apologies.
Technical difficulties, that's okay. I can work with this. So in general, so the point of HelpLink is to be a resource for people who just either don't know where to start, aren't sure where to begin. We know that for many people, if they've never interacted with the substance use disorder system of care or resources, it can be overwhelming. It can be a lot of phone calls. So Vermont HelpLink exists as a one-call, hopefully, resource where people can explain what's going on with them, explain what substances they're using, some general information. All the information that's provided is optional. People don't have to provide anything more than they want to. I think that could be particularly helpful for populations of people who might be parenting or pregnant and have concerns about child welfare systems. Like, they don't need to disclose anything. What people choose to disclose can help tailor the referrals, but it's totally up to them. What we see is, for people who contact HelpLink, by and large, the number one substance folks report is alcohol. That little chart, I think it's 2021, but it's really similar for 22. Alcohol tends to be somewhere between 40 and 60% of all interactions, which in some ways is surprising, in some ways not. We do see a large amount of people reporting opioid use, so that could be heroin. People reporting specifically fentanyl use is ticking up there as that becomes more of a thing. Misuse of prescriptions, those sort of things. Stimulants, so that might be crack cocaine, are sort of lower in the reports. Cannabis, inhalants tend to happen less frequency. So what we see mostly is alcohol, opioid, stimulants. We get, I think it says 1,982 calls and about 59,000 website visits in 2021. I don't know the 2022 numbers off the top of my head, but probably similar. What we find is, you know, when we have promotions and the word gets out there, we do see bumps and people accessing, which is super. And all services, so all of the information referral services from HelpLink are free of charge. No insurance information is asked for. It's confidential. The state don't receive any personal identifying information about individuals. We look at population level numbers, but the total anonymity from the caller perspective. And we can go to the next slide. So, as I referenced, people can access really any part of the substance use disorder system of care through HelpLink. It's not intended to be primarily treatment. We want to highlight resources, everything from prevention, intervention, treatment, recovery, harm reduction, family services, etc. Megan referenced the preferred provider network and how there are substance use treatment resources that aren't within our preferred provider or Blueprint Spoke network. We do not currently have those entities highlighted in HelpLink. One of the priorities for us is ensuring that services that we promote or promote via inclusion in our database are accessible. that they can accept referrals, they can work with clients who might have varied needs, they might, limited barriers for folks, those, and that's what we tend to see in our preferred provider network and our Blueprint folks, versus some of the other private treatment programs might not accept Medicaid. We don't think that might be a good resource for everybody. So those participating treatment resources hopefully will be good fits for folks. And the phone call or the online screener that I will get to in a second here will direct people to those providers. Go to the next slide, I suppose, and that might be it. So I referenced in my words on the website, there is the ability to do an online chat with call takers. So if people don't have access to telephone or they don't want to talk on the phone, they can do an online chat. We have plans probably sometime in the next year or so to take a closer look at text messaging, so that could be an option. The other thing with Vermont HealthLink that we are working on now and piloting is access to appointments with our preferred providers through Vermont HealthLink. I won't get into the behind the scenes technology, but there are some providers are providing appointment times for screenings for that initial touch point. So my goal, my vision is that if somebody calls HealthLink, they seem to be appropriate, say, for an intensive outpatient program. And that program has a schedule provided that in that first phone call, the person could be provided information about short-term resources. So if they're using injection drugs or if they need prenatal care, they can get that on the phone call, get that appointment right there, and then go see the provider. And we will continue to do more work on that through this year. And that's what I've got for HealthLink. So feel free to use it as a resource. If you have any thoughts or feedback, I love to get feedback from people. It's like a living resource that we hope to constantly be updating and making useful for people. So any experiences you have, feel free to email me with those. Room for improvement or things that went really well, it's nice to hear all of them. So that's it for me for now.
Thanks, Mariah. And I just want to acknowledge Mariah stood up HealthLink ahead of schedule in the midst of COVID. So she has done an incredible amount of work to get us as far as we have under quite extreme circumstances. So much appreciated, Mariah. And I also want to acknowledge, we just threw what is literally an 8-hour training at you in 35 minutes. So I do acknowledge that. We wanted to get you as much as we could in a short period of time, but we're happy to answer questions. Mariah and I do have to step off a little before 10 to transition to our 10 o'clocks, but we're available until then.
Thank you both so much. And anticipating a question, I'm sure we'll get, would it be possible for you to email me the slides you've shared today so we can send those out to folks?
I will, but I'll fix the formatting fail first.
No worries. Perfect. Thank you. And it looks like we had a couple of questions. I'm not sure if you addressed these, but it looks like we have a question from Anna and a question from Maria already in the chat. I wonder if you could speak to those. And I'm happy to read them as well if that's helpful.
Got it. Sorry.
No worries.
Is it standard for the SUD? I'm going to read the question. Is it standard for the SUD treatment providers to ask if the person has children, is parenting? So I can speak to the preferred provider network because they're the ones we have standards and requirements for the assessment. So yes. Family constellation, children parenting is something that would be part of an assessment through the preferred provider network. I can't speak to private practitioners. I can say that being a licensed clinician, it is part of an assessment. So I would hope that that is happening. And then the next question, are spokes primary care offices? So when the hub and spoke system was first put together, they were primarily primary care offices. As the hub and spoke system has evolved, the type of program that is participating as a spoke has evolved as well. So there are primary care office spokes, there are FQHC spokes, there are specialty addiction medicine spokes. Savita would be a good example. So their focus of business is substance use disorder treatment, they are also spokes. OBGYN offices have also evolved into spokes. So the majority are still primary care offices, but the spoke system has evolved over time.
Great.
Yes.
Thank you for answering those. It looks like Renee has a question as well.
I do. Thank you for that presentation. That was a lot in a short period of time. And shout out to Mariah. I don't think I've seen you in like probably 3 or 4 years. And I remember when you were building this and getting ready to launch. So congratulations. And it's really exciting to hear, you know, how many hits and how many uses the service has and the gap that it's really filling there. My question kind of picking up on what Anne was throwing down, I think in a lot of the work that we've done and supporting providers with supporting families, you know, some barriers that come up for families with young children who are trying to access some sort of substance use treatment or recovery or support is around transportation and childcare and connections to developmental screening. So I'm just kind of wondering if you can talk a little bit more, like I know that when assessments are being done, we're figuring out if folks have kids and what their family constellation looks like, but I'm curious about how we might be supporting and connecting those folks that have young kids to those services, and certainly thinking about Help Me Grow and developmental screening, or, you know, CIS and thinking if there's substance use disorder. Oftentimes thinking about Part C, IDEA, you know, and families knowing about development, and how are we kind of coordinating and connecting folks to those types of services to really give those kiddos support while their parents are recovering.
Sure. So there's a lot in that question. If I forget something, remind me. So the childcare piece is interesting, and we at one point had one of our hubs through some funding, pilot childcare at the hub, and we had almost zero uptake. And I'm looking at the chat, and Anne had mentioned DCF and FSD involvement. We suspected, and anecdotal information told us that people were not interested in using the childcare attached to our treatment program for those exact reasons. They were very concerned about the potential for DCF and FSD involvement. And you know, we still are very interested in how to partner with childcare, but have not figured out how to kind of get over the hump of that. So I would say if this group has any good ideas, please let us know. The transportation piece, you know, Medicaid has pretty robust transportation as a part of their benefit. A lot of people don't know about how to work with the Medicaid transportation group when there are children who may have to accompany parents on rides. I really encourage folks to reach out to Department of Vermont Health Access and the provider relations group who oversees the contract with the transportation vendor. They're an incredibly good resource to talk about what Medicaid transportation can and can't do. And they're also a really great contact because they oversee the contract with the transportation broker, and things can sometimes go a little, you know, awry, and they're very interested in knowing from people when perhaps something that should be covered under the contract is not being covered. So I'm happy to share with Anna our contact over at Medicaid transportation. I know they do go and do presentations for groups pretty frequently about the benefits. So I think that's a good resource. There's also pilots in a few areas through VTrans, providing some transportation services that for things that are not otherwise covered by Medicaid. So things like recovery centers. Right now, recovery services are not a Medicaid benefit, so they're not eligible for Medicaid transportation. and other things. So I certainly could also provide Anna with the name of the person over at VTrans. That's obviously not our program, but we're aware of it. So that's the transportation piece. Connection to services for children. So, I think I think that's an area where there's some room for improvement. And so, if you think about the workforce in the SUD treatment system, there's an incredible amount of turnover. People turn over pretty quickly. You're always training new staff. And so certainly you connect with those seasoned staff. They know everything in the area. They know all of the resources to refer people to. Obviously, people have a choice to not pursue referrals for a variety of reasons. But I do think there's certainly some opportunity for us to partner to make sure that we are kind of continually educating our workforce about what is available in the communities.
Well, you did a fabulous job at Hit It, because I just threw people who know me in this group knew it was probably coming, and kudos for being able to shield all of that. Again, as Head Start Collaboration Office Director sitting with CDD, I think I can say very strongly that the Child Development Division would love to explore and continue working on these partnerships. It's certainly a priority within the Collaboration Office strategic plan to support programs and families around health and mental health, which includes substance use disorders. So I think in our world, we've often seen those are some folks we want to connect with, because we know folks struggling with substance use disorders have kids, and we believe all of the same things about early intervention and prevention, and we want to pick those kids up early, and we want to really build those connections. So you can definitely write my name down as a contact. I can drop my email in the chat, and I know that BBF and Anna and the whole team there are also really interested in this topic. So thank you for taking some time and giving me a little energy and excitement about some possibilities to really strengthen these relationships.
Happy to do it. I see Anne in the comments had talked about DCF and FSD involvement. That is a real barrier when it comes to collaboration and coordination. People have very realistic fears about the potential for their substance use to be used or to be thought of as a reason why DCF or FSD might need to get involved. There are also, quite frankly, some behaviors, actions around folks who have substance use disorders that DCF needs to get involved for. So I think the mandated reporting, DCF involvement is a really tangled piece for people with substance use disorders, and a really realistic fear for folks, and a barrier for both accessing treatment, but also then accessing other referrals that might be appropriate. And then can I speak to the not really new drug xylazine appearing in Vermont? So xylazine, if folks don't know, is a veterinary tranquilizer. It's not actually a new substance, but it seems to be the new fun thing that business people who are in the business of distributing drugs have decided that they're going to cut into their drug supply. It is appearing in Vermont. It's appearing nationwide. And the question is, do we have test strips for it yet? So there is a company out of Canada who has developed test strips. It is not a CLIA waived, so it's not an approved test, but they do exist.
All right. Thank you. I want to be mindful of both of your time. I know you have to leave us early. I think Kaya had one more question in the chat about, given the increases in opioid usage, are we increasing harm reduction efforts such as syringe exchanges?
So yeah, there is more funding going into our syringe service programs. They are expanding their offerings. That is only one piece of the harm reduction that's being invested in. Narcan is being heavily invested in, distributed, and I think embraced in the state in a way that it hasn't been necessarily historically. Obviously, the stigma with substance use disorders is probably the biggest challenge to folks being able to seek harm reduction services and treatment services. And Narcan was not well embraced in this state for a period of time, but I feel like that's changed. And Lila will shoot me a nasty look if she disagrees with me. But I think, good, I got the thumbs up. So I think that is something that has really expanded and really been embraced. Also looking at wound care, so kind of expanding what harm reduction looks like. Xylazine, many of the other adulterants to drugs can exacerbate or cause pretty significant cellulitis, tissue death around injection sites. So the SSPs and many of our other programs are looking at how to support people in caring for their wounds, injection site wounds as best they can, to make sure that they're not getting septic, ending up in the hospital on IV antibiotics. Mariah said we have harm reduction and safer use in our VT Help Link and obviously on our VDH website as well. So I think there are still varied feelings about harm reduction in the state, but I do think it is becoming more widely accepted. And I see interested in a follow-up discussion about how to navigate parents experiencing SUD fear. Okay. Yeah, happy to, Anne. We've done that. We've actually done a training on that in years past, a discussion with partners. So feel free to reach out.
Excellent. Well, thank you both so much for your time. I think as evidenced by the engagement in the chat and otherwise, people are really excited about some potential opportunities to collaborate on these things. And I'm sensing potentially a ripe area too for us to think about a policy recommendation as a committee. So I will kind of support connections being made after the meeting, and we'll certainly send out all the materials. And I think too, for our committee to keep in mind, we plan on doing, I think probably we'll do one more kind of topical meeting like this afterwards, but then following that, we're going to do a meeting where we kind of look back at the things that we've focused on recently and think about some of those policy recommendations or next steps related to those conversations. So we will let Megan and Mariah go, but thank you both so much for joining us today.
Thank you.
Have a great day. Bye.
Bye-bye.
Thank you. Okay. We're going to quickly pivot now to some of our regional partners. I apologize that went over a little bit, but we had so much to share there. Megan Masterson, I wonder if I can turn the floor right over to you to share the slides I know you prepared for today.
Sure. I'm going to have a difficult time seeing everyone as always. So if you have any questions, just unmute or put them in the chat. So as I said when I introduced myself, my name is Megan Masterson. I'm the Assistant Director at KidSafe Collaborative. KidSafe is an organization that is based in Burlington. We primarily operate in Chittenden County, though we do some more statewide systems level work. This is our mission statement here, that we work together to improve response to and prevention of child abuse and neglect. As I said, our work is done through two primary ways, systems level work, and then directly through various collaborative teams. This is a very busy looking slide that highlights kind of a high level overview of a lot of the things that we do. And I've specifically highlighted, you can see the red boxes around the family treatment court docket and the children and recovering mothers or the CHARM team. And so I'm going to focus on those two today, but we are up to a lot of different things in a lot of different places. So the Children and Recovering Mothers team, or CHARM team, is an interdisciplinary and cross-agency team. We have team members from a wide array of services, and the goal of the team is to improve outcomes for pregnant people and their newborns and infants. And so the team really functions as an opportunity for service providers to come together and improve care and coordination for clients. We have representatives from, like I said, a variety of organizations, including healthcare. So we have folks from the COGS clinic, which is based out of UVM Medical Center. It's the Clinical Obstetric Gynecological Services Clinic. I think I got that right with a lot of words. We have a team member from the Chittenden Clinic. Unique to CHARM is that we also have a member from DCF Family Services from the Burlington District Office. And with the previous discussion around, fear around DCF being involved, I did want to highlight that in particular. The CHARM team was cited by SAMHSA, which is part of the U.S. Department of Health and Human Services, as a model collaborative approach. And so the CHARM team does a lot. We do like hours-long trainings about the team, but I know I have a limited amount of time here today, so I'm happy to give more information about the team at a later point if people have questions. The other initiative that I wanted to highlight today is KidSafe's involvement with the Chittenden County Family Treatment Court docket. KidSafe Executive Director Sally Borden, I'm sure many of you know Sally, is part of the steering committee for the treatment court docket, and so that is how KidSafe is connected. Also, KidSafe previously received funds from Building Bright Futures, which we use to purchase items for treatment court docket participants. Part of the model for treatment court, not just the Chittenden County one, but treatment courts in general, is incentives for participants, as well as providing funds for sort of basic needs that aren't otherwise covered by other services. So I highlighted one example, which was we used the funds from BBF for a parent to purchase new tires for their vehicle, and that allowed them to safely attend visits with their child. So the family treatment court docket is intended for families where there's an overlap between substance use and involvement with the child welfare system. And we know that oftentimes the court timeline for a parent's recovery does not align with the child welfare's timeline for the child and their permanency. And so family treatment court docket is intended to be a place where those two systems can come together and work to align those two often competing needs. It was established in Chittenden County in 2008, which was obviously heavily impacted by the pandemic and the pandemic impact on the court system in general. So it is currently up and running. The focus recently has really been around sort of recruitment for participation, and then improving processes as a new initiative. There's always sort of work to be done in that initial phase of getting things running more smoothly. That was a very quick and dirty overview of two somewhat complex teams. And I know we're running a little behind, so I'm happy to answer questions if there are any. And Anna does have the slides that I just showed, so those will be sent out with the notes.
Awesome. Thank you, Megan. Any questions for Megan, or we can also hold for a little bit of more of a discussion after all of our regional partners, up to you all.
Mariah, yes. So there are other charm-like teams around the state. Franklin County has a charm team. They use the same acronym. In other areas of the state, they go by different names, but there is not, they're all in kind of different phases and look a little bit different in terms of how they function. And there is some work being done to create more uniformity as far as how the teams operate, how they function, so that regardless of where a parent lives, they could have access to that support.
Excellent. Any other questions for Megan for now?
I would just say I've been doing a lot of work in this field and I've seen KidSafe, but I never really understand the complexity of the programs and the work and how they fit together. So as a big visual person, that was really helpful. So thank you for helping me learn something new today.
You are very welcome. Yes, I feel like I still don't have my elevator pitch of what KidSafe does down. It's constantly kind of in flux. So.
Excellent. Okay. Well, given that we're a little bit behind, I want to open up some space for Lila. I wonder if you could share, Lila. I don't know what you've prepared to share with the group, but I wonder if you could just talk a little bit about Journey to Recovery and your programming. I know that Megan Mitchell referenced your work quite a bit, and I think it would be great for folks to kind of get a sense of what you are doing at a regional level, particularly as you can see from this group. There's lots of interest in kind of what it looks like to connect families to some of those other services as well that they might be needing. So it'd be great if you could potentially hit on that.
Hi, everybody. I'm Lila Bennett, and I am the director of the Recovery Center in Newport. And so, yeah, so I was going to show you a little bit about the social detox. I think that was what we had talked about before, but there's a lot more that I can explain. So I'm just going to introduce sort of what we do and how that pertains to young families first. So the Recovery Center is part of that spectrum that Megan shared, but we are not clinical at all. So we are peer support, which means that anyone who works at this recovery center or any recovery center in Vermont is someone with shared or lived experience. And so we are recovery coaches, and recovery coaches are trained. We do have to go through an academy and other extensive training to be able to support people in substance use crisis, but we also are all people who have direct experience in one way or another, either personally ourselves or with family members. And so what that does, and the reason that it's important and a little bit different than therapists or clinicians, is because it kind of levels that playing field, and it allows for someone who might be struggling to talk to someone who's been there. And it's a little bit, might feel a little bit safer or less intimidating. And one thing that we have been doing is getting many referrals from Vermont HelpLink, which that's a really nice, it's like people who are scared, families, parents especially, might start with an anonymous phone call, and then they can ease their way into the system by coming to a out what the resources are that are available. In our area in particular, we do have a lot of parents who are struggling with substance use disorder, and that's both alcohol and opiate, crack. I mean, it's really pretty extreme and extensive, and parents are scared and don't always know what to do. So if you do have parents who you suspect might be struggling, you can encourage them to call the center, and it is a good, safe place to start. Though we are mandated reporters, we do try to really meet people where they're at and figure out what the best course of action is for them. We do work in conjunction with the other community partners like Northeast Kingdom Human Services, Umbrella, NECA, to make sure that parents are supported. But the other thing that we are doing, which we are really excited about, that I actually wasn't planning on highlighting, but after listening to the conversation, I think it's really important. Our center is working directly in the high school. So we have recovery coaches who are in the high school full time, and we are working directly with students. And so what that does is it gets at families in a different way. So we have kids who disclose that they're struggling with their family, their parents, or who, someone in their family who is struggling with substance use. And it allows us to support the kids, to do some prevention and maybe early intervention if they're already starting to cope unhealthily. And then it also sometimes does get us an in with those parents. And so that's something that we're doing a lot up here in this area. As far as younger kids, I think it's really tricky and really hard, but the best thing that you can do is encourage anyone to reach out to a recovery center. One thing that we have been doing is being like a resource navigator in our area. So someone could come and they could say they want some support with figuring out whatever it is that they might need support with. And it might not be directly to do with substances at first, but we can get at them in that way. What I was going to talk to you guys about mostly is our social detox pilot project, which we are doing in this area. It's the first one in the state. And I can share my screen if you guys, do we have time for me? Yeah, okay.
Totally, absolutely.
Can you see that?
Yes, we can.
Okay. So in Newport, our recovery center is right across from the hospital. And so we work very closely with the hospital in helping people who are in that extreme substance use crisis. And what we noticed is in our area, we were having a really tricky time with people who were presenting to the hospital, needing treatment, and there being a long waiting list for people to get into treatment. And lots of barriers, just having those few inpatient facilities that you saw on Megan's slide. There's really only 3 in the state of Vermont for substance use. And so when you have all the people throughout the whole state needing some inpatient level of care, there's this gap. So people arrive, they want help right then, they can't get into treatment quickly enough, and then they go home and then they just relapse and the whole cycle starts over. It just keeps going. So we decided to track the number of people, and this started during COVID in 2020, that were presenting to the emergency room or to the center who needed to go to inpatient and couldn't get in, and then ended up returning home to their triggering environment and relapsing until their next crisis. So we collected that data for about 18 months, and then we did a needs assessment with the Pacific Institute for Research and Development. And we just determined that we didn't need like a gap, like a stop, a place for people to come and wait until they could get into treatment. And so then we applied for a grant through Northern Counties, a health equity grant, and we opened the bed last November. And we have had people, patients, clients in our center in this space pretty much ever since we opened. And what it's doing is it's just providing a place for people to come and access all the resources. It's like we get their intake done for inpatient. We look at everything that's going on. We start their aftercare planning. We do look at if they have children or not. We create safety plans, and it just sets people up for more success to be able to return to their life after treatment with more support. And it also is providing this ability for people to feel safe coming into the center, and they already start their relationships with us, and they know that this is a place where they're going to be treated with dignity and respect and kindness. And so after they return, they want to come back. So it's really supporting families, people who maybe were very ashamed, especially if there were if you're a parent, you put a lot of pressure on yourself, and this is allowing people to get rid of that pressure and that stigma a little more easily. So let's see, this is just a slide to show, the success of it. This is actually a parent. He's very proud to be a part of our success story. He is a parent of 2. He has custody of his kids. He's engaging in our services all the time, daily. So this is a project that is very successful. We're saving lives, and we're able to help people who, once they are in recovery, access the support they need to stay sober and be the parents and the community members that they want and hope to be. That's really the gist of that. I'm gonna stop sharing. We collaborate very, we're in constant collaboration with our community partners. So like trying to make sure that the family, anybody who's coming here is getting the right level of care. So if they need support with NECA, or they need economic services, or they need mental health, we're doing all of that. Working with people going into the hospital and then transferring here to inpatient, like collaborating with the providers and the doctors on medication. We collaborate every day with BART and Savita, making sure people are getting the medications that they need in conjunction with the peer support that we offer. That's basically the overview of what we do. Does anybody have questions?
That was great. Thank you so much for sharing all that, Lila. Congrats on the pilot. It sounds really exciting. It sounds like, I don't know if you addressed this already, I could have missed it, but Maria asked about if there's a second site and where it is.
So we have just one recovery center here in Newport. It's right across the street from the hospital. And I can put the address in the chat. We do have a second, it's sort of a second site, but not really. It's in the high school. We have an office in the high school. And we have staff embedded in the high school every day, well, Monday through Friday with the school calendar. But there are recovery centers across the entire state of Vermont. Megan showed the map, but I think I can get that for anyone that needs it. There's a recovery center in St. Johnsbury would be the next closest one to here in Newport. And then there's also one in Morrisville. And in Morrisville, there's also Jenna's Promise, which is fairly new, but it is a sober living place that's not for parents. You can't bring your children there, but it is for people needing to re-enter into learning how to go to work and have a lot of support around going to meetings, recovery, coping skills, all that stuff. That is another, you know, we don't have a lot of, like Megan said, residential sober options for families. So what we do is the best we can do by trying to wrap around people in the community the best that we can. We do have the Rides to Recovery program, which is what Megan was talking about for people that don't qualify for the Medicaid. RCT in our area, Rural Community Transportation, will transport people to our center, to and from our center, every single day, if that's what they want to do. And we have people that do that. So if you have anyone who has barriers with transportation, we can get around that. And also with Zoom, we do a lot. Anyone can join any of our support groups over Zoom, and we do a lot of coaching over Zoom too.
Excellent. Thank you. And thanks to folks for sharing additional resources in the chat. We'll do our best to capture all these and send them out to everyone afterwards. I'm wondering if there's any more questions or if folks just kind of want to share with our little bit of time left, like what resonated today, or what kind of next steps or thoughts about like barriers and gaps that continue to exist, particularly for families with young children, that we want to continue to learn more about or focus on as a committee as we think about potential policy recommendations or follow-up conversations.
We are a Narcan distribution site. So if you have anyone who needs Narcan or you think we have Narcan, we have harm reduction bags. So the bags have fentanyl test strips in them. They have Narcan, they have masks, they have all of our brochures. So anyone who would want any harm reduction bags, we can also deliver for you to hand out or just have for people to be able to discreetly take if they want.
That's great to know. Thank you, Lila. All right, Becca, I see your hand. Go for it.
I think what's really striking me throughout this morning is the interconnectedness, right? Like we do different things across the state, but so many of the programs and the conversations have really all been kind of across discipline and across geography. And I think to answer your question about like, where do we take this? I would love to have some conversation as a committee about how can we support, right, or find or coordinate with all these great folks. Kind of how do we help promote this, right, and get the word out within the program regions we operate in and or live in?
Renee, take the mic.
Yes, Becca, I'm snapping my fingers and I'm wondering about the potential at because I'm thinking more of the systems, right? Because that's just where I sit. And so this might be a little bit different than your question or thought about working within programs, but I've sat for a number of years on what used to be the governor's opioid task force, right, which then kind of rolled into the statewide prevention task force. Under that council, they used to have a family work group. I think that has stopped. And then the other work group was the intervention, treatment, and recovery, I think, as well. So I'm wondering if there, and I've, in my participation in that group, which has waxed and waned in the last couple of years, not many early childhood folks on the call. I think Amanda, the BBF regional coordinator, would come when she was there. And we have had, I think Dora has been on a few times, but it was striking how little representation there was even in the family work group on kind of behalf of young kids. So I'm wondering, Anna, as we're talking about policy recommendations, if there's an opportunity at a systems level to maybe strengthen connections with the prevention task force. And I'm drawing a blank on the woman who coordinated that, but I'll find that information and send it. But I think there just might be, they have their strategic plan. And I think I felt in those settings, I was trying to like, let's remember these barrier issues around childcare and transportation to childcare and all of those pieces, but to have more of a formal, the state early childhood council engaging in that prevention work as well, there could be some great synergy there.
Totally. I appreciate you calling that out. Katie and then Julie.
I just wanted to encourage us all to be working together too, because there's a lot of work going on with MCH and within Department of Health around thinking of systems of care for pregnant and parenting people, and how are they coming into treatment and how are they accessing OB care, and then how is that translating into that first year postpartum, and also obviously that affects early childhood. So and a lot of planning work and a lot of thinking work with the Perinatal Quality Collaborative with VCHIP. I know Julie, parents on this call, is also really diving into it. So I love all of this work, and let's just keep communicating on what we're doing all across the spectrum, because it's all connected.
Yes, very, very true. Thank you for pointing that out. All right, we don't have much time left. I'm going to ask that Julie and then Kaya and then Darla all go and keep their comments relatively short so that I can take a minute to wrap us up. Julie, I don't think we can hear you, unfortunately. I don't know if you're, it doesn't look like you're muted, but I can't. No, still nothing. All right, maybe perhaps put comments in the chat. Sorry about that, Kaya.
So here's what I can offer for people. I actually sit on the Substance Misuse Prevention Council, and I do speak up, but I'm also really involved in the equity and diversity work, and I see this as an equity issue because we know parents of young children have a harder time. So I will keep marching on, but if people want me to say something or they come up with a topic, please reach out via email or call me, and I will be happy to be, y'all know I'm not a shy or retiring flower. So that's all.
That's great. Thank you for that offer. We'll keep that in mind as we think about next steps related to making these connections. Darla.
Great. Everyone, I wanted to just bring up the point that in all three of my councils in the last month or so, we've talked about substance use in the communities and how that affects children in care. And there's a real question and a real need for some type of training around how to support these families in the best way. So could it be something that's non-biased, something that has a lot of empathy, very non-judgmental, but there's a real cry in my regions, and I'm sure it's not unique to all, just my three regions, but if anyone knows of a training or a facilitator who might be good to come in and speak with some folks, it would be really helpful to a lot of people.
Absolutely. Yeah. Thank you for bringing us back to that, Darla. Especially given that this topic is something that we're hearing a lot from regional councils and regional partners kind of struggling to support people. Kay, I see your hand again. Do you have a recommendation for Darla about someone who might be able to support that work?
No, it's a legacy hand. I'm sorry.
No worries. No worries. I was like, oh, she has someone perfect in mind. Okay, well, we'll keep that in mind. Okay, and we'll do our best to kind of capture things from the chat, like I said, and no worries for folks if you have to start to head out. I do just want to wrap us up with a couple of thoughts. First, Beth and I and the rest of our team will kind of connect about what next steps make sense after this conversation, and if next month meeting needs to be some type of follow-up from this discussion, we will certainly do that. I will send out the PowerPoints and the resources that were shared today and the notes. And then lastly, just want to make a note that we are going to make an effort to move to kind of a more bi-monthly schedule, because that seems to be working both better for our team and better for attendees, and puts us on like less of a pattern of continuously being at like the school break week. It tends to fall during our meeting times. So the next time we connect will be in May, and you can look for information on that agenda and any materials from us ahead of time. But thank you all so much for joining today. Yes, so much of a challenge, Becca, with the school schedules. But we appreciate everyone continuing to make an effort to be present and engaged. Great, so we'll let folks go unless people have any other announcements or resources or things to share. Okay, thank you all for your time.